Thank you very much. My topic today will be on managing dengue in children and an update. I would like to thank the organizing committee, the Malaysian Society of Infection Control and Infectious Diseases and Institute of Clinical Research (NIH) for the invitations to be involved in the webinar today in conjunction with the World Non-Neglected Tropical Diseases Day 2022. I will be covering on 4 areas on dengue management in children. There will be the epidemiology, when to suspect dengue in children with the differential diagnosis that we have to consider, assessment in terms of systematic way of assessing the child, history, examination and lab study, and also looking at some updates on the management decisions, especially with the role of IV fluids in the management of dengue in children. So I'll start off first with epidemiology, just a little bit on the background in terms of epidemiology of dengue in Malaysia. As we know, dengue has been around for many years and it affected all age group. And we can see that the dengue trends over the last 10 years or so in Malaysia has seen an increase and also a decrease, a waxing and waning pattern, which is seen all over the world as well. And if we look at the numbers of infected children over the years, it is the cases are about children are affected about 12 to 16% of the total number of cases in Malaysia. And the mortality is about the same. If we look at 2019 data, children made up 19% of the total mortality from dengue in Malaysia. So if you look at burden of childhood dengue, we know that dengue is a problem for most countries in Asia and also in Latin American countries. And this one study here able to quantify in terms of the burden of the disease in children in these countries. Okay, this is a published papers from New England Journal of Medicine a few years ago. It is basically a study that actually a dengue vaccine trial that was being conducted, and they were able to also to produce some results regarding burden of childhood dengue in those countries participated in the study. In this study, basically 5 countries were involved, including Malaysia. Total of around 3,424 in Asian countries and about 6,000 plus, nearly 7,000 in the Latin American countries. So I think the significant part of the finding of the studies is that they found that about 10% of the febrile episodes confirmed to be virologically confirmed dengue, the VCD, and the virologically confirmed dengue. So all the cases of fever children presenting with fever in this country turn out to be dengue, confirmed dengue, and the incidence tends to be higher in the Asian countries compared to that of the Latin America. The second important data here is that the hospitalization rate, where it's about nearly 20% or 1 in 5 children with confirmed dengue infection will need to be admitted to the hospitals. So this obviously show the burden of the disease is quite significant in Asia and also in the Latin American countries. So dengue can present with a spectrum of illness, as we all know, from asymptomatic infections, probably the major bulk of the infections, undifferentiated fever, and what we are more familiar with, the dengue fever and the severe dengue. And we are all obviously very familiar with the WHO classifications of dengue and dengue with warning signs and also severe dengue. What we really want to prevent is to have children that comes in with severe dengue, where they can be very sick with high morbidity and mortality. Severe dengue can be due to capillary leakage and they're presenting with fluid accumulation and shock, or they could be coming with bleeding with area of or the most common sites for bleeding is the gastrointestinal tract and also the mucosa, or they can present with severe dengue with specific organ involvement, including liver, brain, and also the heart. There are some challenges in managing dengue in children. And we especially in these three areas, we look at the diagnosis. Sometimes diagnosis is difficult, late, because we are not able to recognize dengue infections in children, especially when they present with atypical manifestations, not the usual fever, rashes, headache, the classical manifestation, but with some atypical manifestations like gastrointestinal or other system involvement. And the other one is in young infants, because assessment of young infants, sick young infants, sometimes can be very difficult, and the manifestation can also be different from the older age group. Obviously, the second problems that the challenges in managing dengue in children would be not just the diagnosis of dengue, but also recognizing signs of shock and also occult bleeding. And many times children are assessed or diagnosed late with shock, and because of that the outcome may be affected. And the third one obviously is the role of using the judicious amount of fluids in young children's and in all children's basically, and the difficulties of making sure that we are giving adequate and not not giving too much fluid, and also not giving too little fluids. So I'm going to talk on some of the updates that in the management of dengue in children, and this will be based basically on the new management of dengue in children CPG guidelines, which just came out recently and can be downloaded from the Academy Medicine webpage here. So this is an update from the first edition, which was done many years ago, over 10 years ago. So there are certain things that I think I would like to highlight in this presentation today. Okay, so I will talk on the second area, which is now when to suspect dengue. So it's basically we are very familiar with the with this list of symptoms and signs that we should be considering dengue in children. So live and travel in dengue endemic area. All Malaysians are considered to be dengue endemic area. And then presentations of fever plus two other symptoms and signs: nausea, vomiting, rash, ache and pains, leukopenia, any warning signs. I think the very important points here is to have high index of suspicion. Whenever a child presenting with fever, they may or may not fulfill the criteria above, but dengue should always be considered as a part of the differential diagnosis. And be aware there are certain signs and symptoms which are a bit more different than the usual adult manifestations. And for example, headache and retroorbital pain is not commonly not a common symptoms in young children. And beware of the uncommon presentations, especially in young infants. We should be looking for warning signs of dengue in children. It is similar to that those in adults. Abdominal pain. The abdominal pain usually tends to be continuous pain, not intermittent. Persistent fever. In the guidelines, it is defined as more than 2 episodes of vomiting that amounts to fatigue or requires intravenous fluid. They have mucosal bleed, lethargy and restlessness, enlarged liver, pleural effusions and ascites, and hematocrit, increase in hematocrit and reductions in platelet. And other signs that we should be considering as well in children include refuse to eat or drink, refuse to sit up. That is a sign that possibly the child may have postural giddiness or unexplained tachycardia. There was a study being performed and published from Thailand, which looks at the clinical manifestations of dengue patients in children according to age group. I think the study highlighted there are different manifestations of dengue in different age group. And if you look at the summary of the study here, basically some manifestations are common for all age groups, including fever, nausea, anorexia, and vomiting. Older children tends to present with abdominal pain and vomiting. Young infants tends to have some very peculiar signs and symptoms. For example, they may present with seizures, URTI symptoms like rhinorrhea and cough. They can have diarrhea, they can have rash, and they can have hepatomegaly and splenomegaly. These symptoms tend to be appears to have, at least in this study, shows to be more common in young infants compared to older children. So obviously there are quite a large range of differential diagnoses that we have to entertain as well, and it depends on the phase of the illness. The initial phase of the illness, when the febrile phase, then you could have flu-like syndromes, illness with rash, diarrheal diseases, and illnesses with CNS manifestations. And then you have, when during the critical phase, when they go into shock, then you can have other differential diagnoses, including infectious, malignancies, and other clinical features. With the COVID pandemic, COVID and its complication becomes an important differential diagnosis as well. So COVID-19 can manifest like flu-like syndromes or respiratory illness in the child, and MISC, which is the multisystem inflammatory syndrome in children, can also present, can become one of the differential diagnosis in a child who presented with fever. And so these are becoming an important differential diagnosis that we have to entertain with during this COVID pandemic era. I just like to stress a little bit more about MISC. This is basically a severe hyperinflammatory syndrome, and it's been described in children and adolescents up to the age of 21 years of age. It is a sort of a post-COVID conditions occurring usually 2 to 6 weeks after acute SARS-CoV-2 infection. And the clinical features is that of toxic shock syndrome or Kawasaki disease. So fever is a prominent feature there. It can impact 1 in 3,000 cases of after the acute COVID infection. Majority of them will require ICU admissions, and with a not so insignificant mortality, 1 to 2%. So this is condition that we have to be, all of us have to be aware of when the child presented with fever and appears to be sick with shock and possible rash as well. How can we differentiate between dengue and MISC? So many of the features are actually similar, especially fever, rash, abdominal pain, and altered sensorium. It can happen in both dengue and MISC. A few features that suggest more of MISC would be conjunctival injection, swelling of hand and feet, and the CRP could be extremely high in MISC. We're talking about a reading of more than 100 usually, and other inflammatory markers can also be very, very elevated in MISC. Okay, hemoconcentration is seen mainly in dengue and should not routinely be seen in patients with MISC, and left ventricular dysfunctions is also more common in MISC compared to dengue. So there are features that could differentiate between dengue and MISC. So when we try to look in more details regarding the assessment in terms of history, examination, and lab study, it is important that history is taken systematically, and there must be focus on certain areas of history that will highlight the possibility, not just for the diagnosis of dengue, but also the severity of dengue infection. So the sort of date of the onset of fever, symptoms and severity that the child presented with. There are three important questions that need to be asked in more details. How much oral fluid is intake the child took? How much urine output in terms of frequency, volume, and time of most recent voiding? And what activities could the patient do during the febrile illness? Okay, other things that need to be asked for is are the fluid losses, especially diarrhea and vomiting, and we have to quantify this and look for presence of warning signs. Other part of history that we routinely take should be the family history of dengue, other exposures, and risk factors and comorbidities. For physical examination, we have to look at the general assessment. Mental state of the patient is important. Check for hydration status. The child can be dehydrated because of vomiting and anorexia or diarrhea as well. And the hemodynamic state. The clinical evidence of warning signs should be looked for. Bleeding manifestations like mucosal bleed, abdominal tenderness, liver enlargement, fluid accumulations, for example, pleural effusions and ascites, and other important signs, for example, rash, tachypnea, and acidotic breathing. Okay, the hemodynamic assessment is crucial in assessment for dengue, and I think we are very familiar with this slide again to look at CCTVR, the conscious level, capillary refill time, extremities, peripheral pulse volume and heart rate, and measurement of blood pressure, pulse pressure, respiratory and urine output. And it's very important point that assessment of a child, hemodynamic assessment of a child requires the child to be touched or examined or palpate. So if not, otherwise we might miss the early signs of shock happening in the child. Okay, important point for children is that we look at heart rates and blood pressure in children. Children can have a range of normal heart rate, and it depends on the age of the child as well. So it is very important that we acknowledge and know about this. The heart rate can be affected by child's activity, anxiety, or also fever. When we try to interpret whether it's tachycardia or not, please take this into account as well. Okay, the blood pressure also depends on the age of the child, so there are formulas to look at hypotension in children. I think it's also very important that wherever the child is being assessed or managed, whether in emergency department, also in the health clinics, for example, if you're going to manage a sick child with dengue, that a nomogram of normal values for heart rate and also blood pressure should be made available, so that interpretations of the heart rate and blood pressure can be done appropriately. Okay, blood pressure, when we make sure that we have a proper size cuff as well, because of inappropriate size cuff will give inappropriate reading, and the child may be managed inappropriately in this situation. We do some lab investigations to manage dengue. The usual blood investigation would include full blood count and dengue rapid combo test. I think this is available in most places, and that's usually enough for the early management of dengue. Okay, some of the patients that require admissions may require certain extra investigations, including renal function tests, liver function tests, random blood sugars, and also blood gases. And in some severe dengue or cases that die, and we should not forget to do dengue PCR or viral isolations, so that we will be able to diagnose dengue with certainty. But one caution is that laboratory results should be correlated with clinical presentations of children suspected of dengue. Sometimes children, other illness can present similar to like dengue, and if the child has had recent dengue infection, the serology test may be positive in a child who presented with another illness. Hematocrit value is also important and also have to be interpreted carefully in children. There's also a range of normal hematocrit value for different age group. Overall, we can see that very young babies will have higher hematocrit. Later on, they become much lower, and until it becomes adult value. So interpretations of hematocrit is also quite important for us. and we have to look at the baseline hematocrit on day 1 to day 3 will give us a good pointer to be used as a reference point in children. And it's also an important point to note that hematocrit should not be used on its own to decide fluid therapy. So hematocrit is very useful, but other hemodynamic status, urine output, is also an important component when you try to assess whether the child requires IV fluids or not. Lastly, I'll be talking on management in terms of treatment and management decisions in dengue. I think this quote taken from our WHO guidelines 2009 still hold very true, and I think is the crux of the understanding on how to manage dengue. And the words is the key is early recognitions and understanding of the clinical problems during the different phases of the disease, leading to a rational approach to case management and a good clinical outcome. Okay, we just need to know what is happening, where in the terms of illness the child is in, so that we will be able to interpret the laboratory findings, the clinical features appropriately. So when to refer for admissions, these are fairly similar to the adults guidelines. Presence of warning signs, features of severe dengue, presence of comorbidities and social factors. Infants age group, infants less than 12 months of age is also considered to be a risk factor, and we recommend that children less than 12 months old, because of difficulty in assessments, because of more likelihood if they develop severe dengue to be in having more trouble in terms of management, that they should be admitted to the ward. So when we come up to management decisions, we have three situations. A child can present with dengue fever, a child presenting with dengue fever with warning signs, and also those presenting with severe dengue. Those presenting with dengue fever, the management usually can be managed at home. They don't need to be admitted to the wards. The important points is to have adequate fluids intake. Okay, these are home care advice that is available in the guidelines there, and will be published as a pamphlets to be given to parents to bring home. They have to take an adequate fluids amount, and then they have to manage fever with tepid sponge and antipyretics. And usually the antipyretics they suggested is to use paracetamol with a dose of 10 milligram per kilogram per dose, not more than 4 times in a day. We discourage the use of non-steroidal anti-inflammatory drugs like aspirin or brufen, and steroid obviously should be avoided. We need to identify warning signs early and follow up the patients daily. So the warning signs and the danger signs of dengue infections include certain things like poor feeding, obviously bleeding, vomiting, abdominal pain, drowsiness, pale cold or clammy skin, difficulty in breathing, and reduced urine output. And the child should be followed up daily, and you have the daily monitoring charts monitoring, which includes taking a full blood count and looking at the hematocrit value of the child. For dengue fever with warning signs, all this patient is advised to be admitted to the hospital for inpatient care. They will require monitoring of hemodynamic status frequently, and we use hematocrit to guide interventions. Use of isotonic IV fluids judiciously, and we have to correct metabolic acidosis or electrolytes imbalances as needed. So in terms of IV fluids management for dengue fever with warning signs, we have the flow chart here, which is basically a very familiar flow chart that have been used in the pediatric protocol as well before. I think the important point here is that fluids need to be given. Usually we give isotonic crystalloids starting with 5 to 7 mL per kilogram for 1 hour. And if the child improves, then we start to titrate down the IV fluids according to the hemodynamic status, urine output, and hematocrit value. And usually the IV fluids should be able to be stopped within 24 to 48 hours. And the important point is not to use hypotonic solution, for example dextrose 5%, half normal saline or 1/5 normal saline. We have had cases of children being inappropriately resuscitated in health clinics with hypotonic solutions. A child walks into the clinic with dengue fever with warning signs, was run with IV drips, hypotonic half normal saline, and half an hour later the child had a seizures because of hyponatremia. In terms of for severe dengue, child with severe dengue, these children requires emergency treatment and urgent referral. With severe dengue with compensated shock, the algorithm here, it is very important that we make sure that at least the child has a continuous ECG and pulse oximetry monitoring, and that when we give IV fluids in children, that we use infusion or syringe pump, not just a drip method, drop method. The IV fluids need to be given at a bolus of 10 to 20 mils per kilogram over 1 hour. Then reassess again. If the patient is stable, then we can gradually reduce the rate of infusion similar to that for patients with dengue with warning signs. Those unstable, we check the hematocrit value. If the hematocrit is high, suggesting that the patient has not get adequate fluids, we give second IV fluid bolus. If the hematocrit is low, then consider that it could be bleeding and that we might have to use fresh packed red cells or fresh whole blood. And the dose is 10 to 20 mils per kilogram. In children that presented with severe dengue and hypotension, the management becomes more urgent. We have to stabilize the child and run IV fluids 20 mils per kilogram over shorter period of time, 15 to 30 minutes. Reassess again. If the shock has been reversed, then we can gradually reduce the rate of infusion as we have done before. If the child is unstable, again check the hematocrit, and the hematocrit is high, we can give another IV fluid bolus, and we consider that probably for the second bolus that we use colloid solutions rather than crystalloid solutions. If the hematocrit is low, consider that the child may have occult bleeding and give fresh packed red cells or fresh whole blood. And if it's refractory, then we have to reconsider the condition and consider a few factors. The child may require assisted ventilation. Consider that the child continue to have bleeding and also leaking at the same time. Look for the source of bleeding if possible. We may need to transfuse fresh packed cells again and again, and also other blood components, and we have to check coagulation profile. Also consider, could this be co-infections and child is having septicemic shock, and we have to take blood cultures and start antibiotics appropriately, and consider using of inotropes or vasopressors. And then we have also consider whether there's myocardial dysfunction, and echo would be helpful in these situations, and inotropes or vasopressors will also be required in these situations. And we have to always correct the electrolytes and acidosis, as this will cause child to not respond to treatment as accordingly. So types of IV fluid in dengue, I've mentioned that crystalloid solution is the fluids that is recommended to be used for resuscitations and maintenance therapy. So the isotonic crystalloid solutions include full normal saline, Ringer's lactate or Hartmann's solution. You can also use stereofunding if you have that available for you. Colloid solutions can be used in certain circumstances. This includes persistent shock despite resuscitation with the crystalloid solutions. There are a few different colloid solutions that is available to be used. So in the circumstances where you have an obese or overweight children, so what weight should you use for these children? Yes, we use ideal body weight for children. There are multiple methods to calculate ideal body weight. There are at least 4 different methods in the literatures. Some of you will be familiar with at least one of the methods. So if normal height 5 to 95 centile, we usually recommend in the guidelines to use more methods, which is the ideal body weight is the weight for the age on the same percentile as height. Okay, if the child is tall and obese, there is more than 95 centile in terms of their height, use Maclaurin method, which is looking at the weight at 50th centile for height and age. This is an example of Maclaurin methods. So finally, take-home message. We have to consider dengue in any child presenting with fever, and remember that they may present atypically with, for example, upper respiratory tract infection, with febrile seizures in young children, and this sometimes can confuse in terms of diagnosis. Dengue should always be considered in any child presenting with fever. Secondly, you have to assess the child thoroughly and systematically. You have to have focused history taking and physical examination and perform relevant investigations to support the diagnosis and for monitoring of the patients. Monitor the child adequately. Frequency of monitoring based on phase of illness and severity, and emphasis should be on hemodynamic status, hematocrit value, and urine output. And IV fluid should always be used judiciously in a child, because the child is at higher risk of developing whether under volume because inadequate fluids resuscitations or overloading because too much fluids be given to the child. And most of the time, isotonic crystalloid solution can be used for resuscitations of the patients. Thank you very much.